Luba, actually, what is my full name, but I go by Luba, so if you guys have any questions, you can refer to me. We'll start on the HIV. I did HIV for 2 years. I've seen quite a bit, even though at that time it was 2014, 2015. I've still seen a lot more advanced AIDS and opportunistic infections than I ever thought that still existed in this day and age. So a lot of it, of course, is from lack of care and patients being in denial. And so I may, if we have time, squeeze in a few stories of a few patients that really kind of stayed with me for years and years. So we'll start with HIV. So HIV-1 and HIV-2 are both retroviruses. HIV-1 is, if you're going to see HIV, that's probably the one you're going to see. That's the most common one. And HIV-2 is less aggressive, and usually we see it in some parts of West Africa. We do see a small percentage in the United States as well. I haven't seen it in my clinic when I practice, but most labs you order, I believe, will run for both. So most of the time you don't even need to mention it, but I would always make sure that if you're going to test, you test for both, even though the other one is so rare. So it's RNA virus. Once it integrates into the host cell, it becomes part of its DNA, and then once it's replicated again, it becomes the RNA. HIV virus likes to attack CD4 cells. It can replicate in small numbers and sit dormant in other tissues and fluids as well. But most of the active replication is in the CD4 cells. And that's important because that's the leg of the immune system that it's going to affect as CD4 count declines. And all the opportunistic infections that you guys will talk about, this is what you need a good, healthy CD4 cell count to fight off. And so these are not organisms or infections that you would hear much unless it's someone who's immunocompromised, specifically with the low CD4 cells. So let's say that you have someone in your clinic, you have a 25-year-old female, she's crying, she just got contacted by the health department. A lot of times that's how my patients found out, is once someone came back positive, especially if there were some other concurrent sexually transmitted diseases, gonorrhea, chlamydia, or syphilis. They had a nice chat with health department, and they went over if they could remember all of their contacts, sexual contacts, and then those folks got notified and they went to get tested. So she's encouraged to get tested. She doesn't know yet. So you're trying to figure out if she's positive, and then you're doing your physical exam, you're thinking about what labs you're going to get. There's a rapid HIV testing, but let's say you're in rural Oklahoma, you don't have that available, you have to do the full blood work and for it to come back to find out if she is. So you're trying to figure out if she's positive, and if she is, when was it that she became infected? And that's important in our minds because you will try to figure out what other blood work or what other testing you're going to do based on, are we looking into an early infection? Are we looking into someone who's been positive for years? Or is this someone that is most likely going to be in AIDS status? So a couple things is to see if she's, well, first of all, if she's ever been tested for HIV, at least you'll know a definitive no on when she wasn't infected. You can get a sexual history on her, see if she uses any condoms, if she uses any barrier protection, and who she used it with and who she hasn't. You can also see if she's ever donated blood. That's going to be as good as HIV test, and they're going to be contacted if that comes back positive. So she donated blood as a senior in high school, and she's had multiple partners. She's not the one to use condoms, and she's 25. So you would say that your fair bet is probably a few years. That's what you'd estimate. So, so some of the questions I've already went over what you would ask her to try to figure out when she get infected. We'll talk about some physical exam findings that may help to clue you in before your lab work comes back, how you would interpret your blood work. And then we'll also talk about HIV medications. You guys are going to have a lecture specifically on HIV medicines, but I will give you a list. I'm not going to use any brand names. Everything in my slides is just going to be generic and their abbreviations. And I will just pinpoint kind of big highlights, big deals, the most important points about the medications and the drug interactions and things like that. So let's talk about numbers. I like numbers because this tells us how well are we doing as far as, we can't eradicate the virus, but if we can slow down the transmission, maybe eventually will die out, no one will be infected. So there, in 2008 versus 2016, worldwide, we were looking at about 33.4 million versus 36.7 million. Now, that's a tricky number because if you look at the newly infected and death due to AIDS, those numbers are actually lower. So what's happening is that our HIV patients are living longer and they're having better lives. With the medications that are available, that are very good, that work very well with very low side effect profile for most of these newer medicines. But we still are not where we want to be as far as new infections are concerned. In numbers for 2015, 13 to 19-year-olds, so these are tweens and teens, about 4% of them are of that age bracket. Your largest age bracket, 37%, is your 20 to 29-year-olds. So have high suspicion in that age group. I've had a young patient that had a horrible shingles infection that kept coming back to emergency room with this huge dermatomal. I mean, it left scar, huge scar. Young, homosexual male, very thin, borderline cachectic, and no one. He was 22. No one ever once thought to test him for HIV. 24% 30 to 39, and a quite large number, 12% of 50 to 59-year-olds, and then we see older than 60 now, the population, and we have about 5% of those as well. So your transmission rate, heterosexual contact, one contact, we have about 21%. Male-to-male contact, about 1%, needle stick, 0.3%. Blood transfusion, of course, is very high, but still, even that is not 100%, 80% if they'll become infected. And mother-to-infant transmission was a huge one in third world countries, and now we've brought it down to about 2% with medications, routine testing of all pregnant women. Before, if they've never had any prenatal care, then they need to be, as they're in labor, they need a quick rapid test to get tested. And here, high-risk OB here, not here, at OU, I keep forgetting OU is no longer the only program. At OU, as this woman's in labor, that's one of the things you definitely need to do if she's never had any care, and this is the first time that she's presenting to care. Now, elective C-section used to be the routine, and now there are actually lot more women now that are delivering vaginally, and these are the patients that are compliant with their medications, they have non-detectable viral load, and it's kind of an individual based type of thing. But if, you know, a woman comes back positive, she's in labor, she didn't know she was positive, she had no prenatal care, she'll probably get a C-section. And again, there's some factors that may play into it why she wouldn't. But so who should get tested? This went on for years and years and years. We had a long list of who we were going to test, and then the list got larger and larger, and it got smaller and smaller, and we're trying to see the high-risk patients and the homosexual males and high-risk behavior and IV needle sticks and IV needle sharing and drug users, and then eventually we just came to this realization that there are a lot of heterosexual that are non-high-risk behavior women and man that get infected. So you cannot just go based on this list. So they say everyone. Everyone from age 13 to 64 once in their lifetime, probably during their routine physical. If you do OB, if you do primary care, someone presents to care and they say, okay, I want my yearly physical, I haven't been to a doctor, I want everything done. And you just throw in the HIV testing in there. Have you ever had it? No. Let's do it. And it's no longer a big deal, so to speak. So you don't go into, okay, can I please test you, or, you know, sign these forms. They don't have to sign anything. You can rattle it off. Okay, you have not had any medical care in a while. You haven't seen a doctor. I'm going to get a CBC, CMP, check your electrolytes, check your liver, check your kidneys. Let's get in the cholesterol in there. You're of age. Sexually active, you're single, okay, let's go ahead and get a HIV test, let's do this, and you just list it off. Now, they're all the stuff they rattle off, you rattle off, they say, you know what, I want all this done, but I don't want this, and I don't want this, which very rarely do they say that, unless it's an expensive MRI or something like that. Will my insurance pay for that? Otherwise, they'll just go, okay, doc, it's up to you. You guys are going to be called docs so many times. Sick and tired of correcting them. And if you do have a patient, of course, that is a high risk, then I would go ahead and encourage them to be screened annually. And it doesn't even have to be a high risk. You have a single female. She's single, she's not married, she hasn't been in a long time relationship. She's your OBGYN, like you came in, you work for an OB. Throw that into her yearly exam and get her tested. So I've mentioned some of the patients already as far as the high-risk group. I don't have to go over that again. I do want to point out in there that if they have a concurrent STD or STI, then the risk of them transmitting the infection is much higher. And it makes sense. If there's angry, irritated tissue, then you're going to be most likely to pass on something that is blood-borne. Genital herpes, if they have an active outbreak, so we're not talking about latent virus that never come out. They've got active outbreak. They're 25-fold more likely to pass on the infection. If they have a syphilis lesions, there's increased risk, and your gonorrhea, chlamydia as well. They use IV drugs. If they've received blood products before 1985, and there's very few patients that are left, and these were your hemophilia patients that initially had the large outbreak as the infection came into the United States, and so unfortunately a lot of these folks are no longer alive. So it's very rare that you would see someone receiving it from a blood product. And needle stick injuries. I had a patient that said that he dove into he could tell me exactly when he got infected, because he said he dove into a trash can and he pricked his finger, and he doesn't know what it was. It was a needle or a nail, but He swears it was from him diving into that trade. It was a long, elaborate story. There's no way this is how he got infected. But, you know, I don't care if you tell me the right story of how that happened, but if you can approximately tell me when, right? So he knew something happened at that time. It was the diving into the trash can. Gay and bisexual man, also young African-American gay or transgender, transsexual, young African-American males. If you look up under the statistics, and the more prejudiced certain group is, I've seen a lot of patients with lower self-esteem. I've seen a lot of young kids that got kicked out of the house with their dad or their mom or the whole family. They ended up on the street. They found a group. You know, their likelihood when someone's feeding them and providing them shelter to say, you know what, you either use a condom or you don't come near me. Likelihood of them saying that is slim to none. So these are the folks that, unfortunately, lots of stories that I've heard that you know, few where you kind of walk into the room and somebody's just sitting in the corner, crying and rocking, and kind of step out for a few minutes, take a few deep breaths, come back in. Some of these folks, it was very, not just the HIV status, but just their lives been pretty difficult. So if you guys in medicine, I know you have compassion, but have compassion for these folks. They've been through a lot. So risk reduction, of course, consistent condom use. I chuckled at the news reports. Have you guys seen that some teens are washing, reusing their condoms? Yeah, that's going to help a lot. Yeah. They're cheap. You go to any, there's lots of places that have balls of them. But yeah, no, that's not going to help. It's a one-time use still. IV drug users. Now, for some of these, and this came out, and I really was thrilled at seeing this because there are several of my patients that I felt could have really benefited from this. But they actually, so as we later talked about treatment, you need a 3-drug component. You need 3 drugs. You know, virus is very smart and it highly mutates. So we've not been able to find one drug or even one drug that works consistently. So not only do you need 3 drugs, we're constantly monitoring. There's a test you can order to check viruses' genetic makeup, and if they're failing their therapy, you can constantly check them and see which drug has their virus mutated against. And if their virus mutated against one drug, the other 2 at risk because you have to have 3. So then you quickly figure out, you know, what you're going to do. And so a lot of these OU infectious diseases works very closely with pharmacists. You've got to have pharmacists on board. Otherwise, or you got to have years of experience because it's very tricky to treat HIV. So Truvada is a 2-drug regimen, but they approved it for pre-exposure prophylaxis, and I've had some couples that's been married for years and years and years, and they use condoms, but you know, things still happen. And so you would have one partner that's HIV positive, one negative, and I felt if at the time of practice, I was at OU, if you could give them like something like Truvada for pre-exposure prophylaxis. Now, if their partner's got a non-detectable viral load or really low viral load, then technically, now I didn't say that to too many patients, but technically their risk, even without a condom, their risk of transmission is incredibly low. That's why we want these folks off the streets or on the street. We want them on meds. That's as close to the vaccine as we can get, is to get their viral load incredibly low. The higher the viral load, the more infectious these folks are. But putting some of these spouses, partners on Truvada would have definitely helped. But that came out about 3 or 4 years after I quit doing infectious diseases. And then your healthcare workers, your needle sticks, those folks, you start as soon as possible, and they get the or, you know, a sexual assault victim, they're gonna get 3 medication combination. Most likely, they're gonna get atripla or a 3-drug regimen. So in those folks, we're gonna assume that they're positive, and we're gonna go ahead and give them, and see if by taking the antiretroviral regimen, by taking the drug, we can prevent them from virus replicating, spreading, or from them getting infected altogether. It's incredibly difficult to study to see just how effective it is, but as soon as someone, within 72 hours, as soon as someone's exposed, or they may have a blood exposure that you work in the hospital and the patient's gone and there's no way to go backtrack and test them, so you don't know what their status was, and you had a blood exposure, you had a drop, you know, in your eye, drop of blood somewhere in the mucosal surface, like your eye, you had a needle stick, then you can go ahead and start. And every hospital and every clinic, especially if you work in a higher risk clinic, will have a protocol that you're going to follow. You're going to take a test on blood-borne diseases, and almost everyone in the hospital kind of looks through the protocol, and they have to know what they have to do, and you know where to go and where to get it. But you will be given, the regimen. So test high-risk patients, test patients that haven't been tested in a long time. Before every new sexual relationship, I talk to your patients, your younger patients, about making sure that they get tested. I believe in Oklahoma there was a law before you got married. You had to get some testing, including HIV testing, and then a few years back they reversed that. So now, and that was around the time that I had a patient come in. He was very sick. He was just from the hospital. He's in the wheelchair, and while he was in the hospital, the whole church was there praying. He was very active in this church, and his wife was by his side. You know, he had an opportunistic infection. He had we'll talk about the virus that he got later on. He paralyzed him, and you know, he was told he has AIDS. He cried, and so his wife was heartbroken because she found this Christian, honest man, and so he was positive for years, and he knew it, and he already had a wife that passed away with AIDS, and I think psychologically he went into denial of some sort, and so he infected his new wife as well, and so when they got married, she wasn't required to get tested. She didn't get tested, so with the way that we're going to test with these patients is you're going to try to figure out when they got infected. Again, thinking about our 25-year-old patient, you think about, unless you can narrow it down to one, or they only did, you know, IV drug once in their lifetime and they had some flu-like illness, unless you can with certainty say that it was around this time where someone had an exposure, needle exposure or needle stick or something like that. Most of these you're going to be getting your immunoassay, antigen antibody testing, and we didn't used to routinely add a viral load as well, but I believe lately with the guidelines, I believe they're also doing the viral load on a lot of these folks, because the immunoassay can come back a little false positive, and then the patient has that time of anxiety waiting for the viral load. So if you're early into infection, then your immune system may not have had time to develop the antibodies yet, but your viral load is going to be high. And I'll show you guys the table down a little bit later. You're going to have, until right before your death, you're going to have almost the highest viral load you've ever had within those first few weeks. So if you have a very high viral load, but your antigen antibody immunoassay is negative, this patient is positive, but early into infection, a few weeks into infection. And then if you have both that are negative, your immunoassay and the viral load is negative, so then you'd say, okay, you're negative, but if you have a very high suspicion or, you know, sexual assault victim or someone like that where someone is early into a possible infection, you retest them in about 1 to 2 weeks, and then maybe even 2 weeks after that if you have a very high suspicious. And again, you would get the immunoassay and the viral load to kind of keep an eye on them, make sure they do not become infected. And the most immunoassays are going to have the both HIV-1 and HIV-2 immunoassay, so it's going to say as it comes back that it's, which type they're infected with. But you may, at your clinic, you may want to check, when you mark that HIV test, when you circle it, you may want to check with your girls at the front that put in the orders in the computer. Let me see, what are you marking? Does that have both on there? So with HIV, you have the primary HIV infection, we have the chronic, kind of a latent state, and then we have advanced AIDS. Early into infection. So in the blue there, you have your CD4 count. In the red, you have the viral load, the RNA copies in the sample of blood. And on the bottom there, we have time in years. So you can see initially, within the first few weeks of infection, your CD4 count, the CD4 count is going to decline quite a bit. This is when the virus replicates rapidly and the body can't keep up with demand, so the CD4 count drops. It's unlikely they will drop to the AIDS level within a few weeks, though. That would be very rare. So if they're below 200 CD4 count, this has not been a few-week infection type of thing. And their viral load is going to skyrocket. Then after a few weeks, close to a year, you may wave up and down. Their CD4 count may try to come up a few times, viral load come down, come up, and then they're going to, for a few years, they're going to have kind of a very slow, steady decline in CD4 count and very slow, steady increase with viral load. And for this whole table is without treatment. For a few years now, you're looking at about a 10-year span here from the time of infection until the advanced age and time of death. But that 10 years doesn't happen to everybody. I have seen this one, the kiddo with the shingle, call him kid. He's 22, but he looked like he was 15. His first sexual contact was, I believe he said, at age 16, and by the time he was 22, by the time I saw him, he was discharged from the hospital with cryptococcal pneumonia, and that's an opportunistic infection, so he progressed to the AIDS. If he got infected from the first contact until the time he went into the AIDS, that was only a few years span, so that was not a 10-year in the making. And everyone's different, and based on individual immune system is eventually what it all comes down to. Some people's bodies are unable to supply such high CD4 count and make those cells fast enough. The viral load skyrockets and the body just comes to it. But there are patients that can actually go for years and years and years with almost non-detectable latent viral load. And I've had only a couple of those. So those are pretty rare, but their bodies is able to keep them like that. And these are patients that are probably in some research studies. We're studying these folks. What is it that their body's doing? They're still infectious. They're not as infectious. Again, your infectivity is dependent on how high the viral load is in the blood. But so after clinical latency, after a few years, then these folks would once their CD4 count drops to below 200, and we'll talk about 3 big opportunistic infections that we've seen the most through the years, and one of them, once your CD4 count drops below 200, another one's most likely once it's below 100, and another one is once you're below 50. And so at that point, some of these organisms we encounter every day living, and our bodies don't think much of it. But when you're immunocompromised, you need to stay. So in primary infection, about 40 to 90% of these patients may have a symptomatic illness. And so this was me being a detective, this is just to try to rack their brain. Is there at any point, do you remember that you had a flu-like illness, but it lasted a bit longer than the flu? It wasn't just a few days. No one around you was getting flu, and all of a sudden you kind of didn't quite feel well. These folks may have enlarged lymph nodes. If you see diffusely enlarged lymph nodes on a young individual, you know, you palpate their clavicles, you see the neck, you know, behind the ears, and do two things. Think cancer, HIV. Don't forget about the HIV. We freak out about cancer when we feel lymph nodes, but HIV tends to be somewhere back. I had a patient that actually ended up getting a lymph node biopsy before they got diagnosed with HIV. So think of those things too. And this clinical illness can last up to 4 weeks. They may not quite feel well, they may feel achy, so fever, again, that's why I'm saying flu-like, but they're going to have some lymphadenopathy, up to 74% of it. Only 70% of them have rash, but this is a very, very specific type of rash, so it's non-confluent. There's not many facial lesions that you would see, and adults don't break out in rashes when they spike a fever. You know, kiddos do that, adults don't. So if you had an adult that broke out, especially a facial non-confluent, less than 1 centimeter rash, then you think HIV. And if you see someone who's got rash on palms of their hands, what do we think about? Syphilis. There's not that many rashes that come back with the, you know, I had a patient that went through several emergency rooms and was diagnosed with hives over and over. 3 times he got Benadryl and Benadryl IV and something else Benadryl. And until I saw him and he went, hi, I flipped his hand over. There it is, right there. And I could see it down the hall. He had it all over his neck. I had to take his shirt off. He was covered. And so that's another one of those. You know, you won't see a whole lot of facial rashes, and you're not going to see a whole lot of rashes on the palms of the hand. But that's a soapbox. So when in the primary HIV, get some blood work, see how their liver doing. Their white cell count may decline. Because of that decline in CD4 count, their total white count may drop. They may have some low platelets. And then you may have your immunoassay negative because of the body hasn't developed those antibodies yet. And you have the chronic asymptomatic phase. We've talked about it before. So I throw in that our patient, a young 25-year-old female, had no signs of symptoms of opportunistic infection, and her last HIV test was about 7 years ago, or negative blood or something like that. So then she may be in this chronic asymptomatic phase. And then you have the advanced AIDS, and typically within 2 to 3 years they succumb to some type of infection unless you get them on antiretrovirals and get their CD4 count up a little bit. Now, they went for a decade, and some go for a decade without much of a CD4 count at all. I had a patient with CD4 count of 1, 0 actually eventually. He did eventually become compliant. In this day and age, these are patients with psychiatric illnesses or socioeconomical status to where they're homeless and they're drug users or something like that, and they come into care. They come into ER with opportunistic infection of some sort. They get better. They start on antiretrovirals to go. They quit taking everything back, and so eventually he went from years of non-compliance. He became compliant and took his antiretrovirals. I think he was positive close to 15 years by this point, and had CD4 count of 1 or 2, and he probably made it another 5 years, but there was almost no immune system, and there was no coming back. The CD4 cells, his body hasn't seen many CD4 cells in so many years that it just never made any. Usually the immune system will reconstitute. That is a severe case. So if someone's starts in antiretrovirals, a lot of them do really well, and they will, some of them would go up to close to 200, some even up higher than that. Some would go back to the normal levels, and it would depend on the immune system and how well their bodies can handle the infection. Opportunistic infections we're going to talk about would be species pneumonia, the CMV, cytomegalovirus, and the mycobacterial infection, but not the tuberculosis, the non-tuberculin mycobacterium. I wanted to put the list of all the others in there as well. A few things to point out is wasting syndrome. These patients, especially in advanced stages, some of them don't have the appetite. Some of them have thrush or esophageal candidiasis, so it's painful to eat and swallow. So that's part of the reason they're losing weight, and their body is spending so much energy trying to fight this thing that the body just doesn't keep up. They lose massive amounts of weight within a few years spans. Invasive cervical cancer is another one, and these are the women that you're going to keep a very close eye on with the viral load, with the lower immune system. And again, it's a virus that causes that cancer, so if they cannot keep the virus at bay, they're going to be at higher risk. And I've seen some pretty advanced cancer in a couple of my AIDS patients. I already mentioned esophageal candidiasis, Kaposi sarcoma. We don't see that very much, but that that skinny patient with lots of purple patches all over him. That was kind of the face of the 80s with the scare. And I had the fortune of knowing Dr. Greenfield, who was an amazing infectious diseases doc. He actually passed away on AIDS Day. But talking back when he was a resident and he was going through this and the HIV, there's a lot of infectious diseases docs that changed specialties. They couldn't do it. All you could do is just do supportive care, didn't know how it was transmitted, didn't know the patients came down with opportunistic infections and cancers right and left, and it was just devastating. There's a lot of infectious diseases residents and there's a lot of them that didn't go into infectious diseases primarily. He was one of those that stuck it out during the residency, and as eventually the meds started to become available. And one fantastic movie that I'd recommend seeing, and of course I'm going to recommend it now, I can't remember it, Dallas Buyers Club. If you guys haven't seen it, you've got to see it. It's treating that patient population, seeing everything that I've seen. That movie embodies the stories that Dr. Greenfield told us, and some of the stories that the patients told us, the older patients that made through it. And now we're doing really well with these meds, but they went through some pretty horrific side effects from some of the medications and how they were treated, and that movie is fantastic. So as you talk to your patients now, as you walk into the room, you see someone crying or walking in the corner, you come out, you come back in, you reassure them. And the best thing I can do is put something really threatening and awful like HIV status or HIV positive and AIDS, and add something to it that they know somebody that made it through. So I like to give it an example as a diabetes type 1. 2, a lot of them, if you lose the weight, you probably can cure it, but the type 1. So let's say, how many people do you know that have the diabetes? They are on insulin every day. They watch their diet. They have to see their doctor regularly. They have to get a regular blood work. They cannot skip their meds, or they can't skip their insulin. They're going to die, but they live, they take care of themselves, and they live long, healthy lives. So can you, if you understand, if you educate yourself on this, if you ask the right questions, the more patient knows, the better they are at being able to handle their health. So how many patients come in and they don't know what medications they're taking? You can either roll your eyes, or you can go, okay, here's what you do. You call your pharmacy. You see what medications you're on. Ask your pharmacist to give you a printout. give it to your granddaughter, have her write it out on a really small card, put it in your wallet, have someone do this for you, so that they know, what they're taking, they know what, the more they know, the better they do. So as far as the blood work on your patients, a lot of this I've done initially as they presented to care. If they're HIV positive, they automatically got referred to the infectious diseases, and here in the city, they probably get an appointment pretty quick, either at OU or a couple other infectious diseases docs in the city. But if you're somewhere far out, and it's going to be a while before they can make it to the infectious disease, you can go off this list, and I would do everything on there. You're going to want to want to know what their CD4 count is. How strong is their immune system? And what are they at risk for? If their CD4 count is really low, what I need to worry about? What's their viral load? Your platelets, your electrolytes, your liver enzymes. Going to do a quick UA. From the UA, you can do check for a couple STDs. You're going to draw your RPR to see for syphilis. You're going to screen for all the others, and you get the PAP on the female for all the other sexually transmitted diseases. You're going to do the TB skin testing. And I think they've gone away from that at the health department now that we have the AGRA testing with the blood. I will tell you that with the tuberculin skin testing, there's a lot of foreign folks, including myself, who've gotten the vaccine for TB. And so my tuberculin skin test will always be positive. So the other test is the only test I get. And they sometimes request for the X-rays, but if they're from a foreign country, I wouldn't even bother with the tuberculin skin testing for some of these. So you're going to do I'm from Russia, by the way. You're going to also check them for the hepatitis A. If they're not actively, you'll know if they're safe. But you're going to do the B and C serologies, and for hepatitis A to see if they're immune or not, because you're going to want to vaccinate them, not because you're going to treat Hep A. But see, we don't have a vaccine for that. But if they're not vaccinated, do the full panel, not to see if they've been exposed, but actually if they've got the antibodies, so that you can see which ones you need to vaccinate. Do the glucose and the serum lipids. These patients, as the HIV populations got older and older with antiretroviral therapy, I'll mention a medicine that can actually, one of the HIV medications that can actually increase cholesterol. So you're going to want to get their lipids before you start on one therapy, so where did they have high cholesterol before that, or did I do this to them? And they are at higher risk for heart disease too, and of course the diabetes and the high cholesterol combined with all of that puts them in another category at high risk for heart disease. And the drug resistance testing is something you will do if you are in infectious diseases, most likely, not in the primary care setting. But this was a very scary, eye-opening experience of knowing that the virus is very smart. It replicates, it develops memory to a certain medication, and then it keeps it. And it keeps it, and you can pass it on to someone else. And so about 20% of these patients that we would get them tested for, their virus tested for drug resistance, would have a resistance already to one of the drugs. It's either lamotrigine or zidovudine. Now again, those were the medications that initially, when we first started treating the virus, and protease inhibitors, I believe that's what he gets in the Dallas Buyers Club, where he goes overseas and gets it. That was something, it was just one medication, but you could keep the viral load at least lower. None of these initially actually made the viral load non-detectable, because one medication won't work, but it will work to keep their viral load lower, and eventually the CD4 count can't handle that viral load, but they can live longer, because the lower their viral load, the longer they're going to live. That 10 years can turn to 15, 20 years. So initially, these folks survived, even though the virus was still replicating. It's just instead of replicating this much, it was replicating this much. So it prolonged their lives. And eventually, they did succumb to AIDS or some type of opportunistic infection, but it gave them 5 or even some 10 more years, depending on their immune system. So this is the drug that you most likely 20% of your patients they're going to have a resistant strain to that right away. You're not going to start that medication on them, because if you do a triple therapy and that's one of the meds, then they're going to quickly become resistant to the other 2. So you're going to document that, and you're going to avoid that medication at all costs. You don't want them to become resistant. And again, patients coming in and out of prison systems, it was patients with lower IQ, it was incredibly difficult trying to figure out, especially if they've been on meds, what they've been on. You expose them to 1 or 2 medications, someone doesn't know what they're doing, they started them on a whole new regimen, and they were resistant to 2 of them, they're resistant to the 3rd. Now this is also tricky, because when they first come in without medications, they're going to have that resistant virus hiding. So it's like a garden variety, so to speak. You're going to get weeds of every sort. But then you start them on that medicine, they're resistant to one, and all of a sudden that virus that's resistant to one of the triple therapies survives, the rest die. And so you put them on a regimen, you didn't see any resistance initially, you put them on a regimen, and all of a sudden they swear they're taking it, but their viral load is creeping up. And you go, okay, what's going on? So then while they're taking this medicine, you check their virus again and see what's going, well, apparently you're not only resistant to this, your virus is also resistant to 3 others that I didn't know about until I started you on the regimen. So by the time I was changing jobs, I had one patient, and I have no idea what all happened to him, but since then there were probably 3 or 4 more HIV drugs that came out on the market, so hopefully the pharmacist was able to concoct something for him, but he was resistant to all but 2. So the virus he has is potent. There is nothing, almost nothing available. At that time, I was going to talk to Dr. Lipke, and I never got a chance to show what we're going to do with this guy, because, and this is what he can pass on, and this is the virus that someone can get. So with your CD4 count and your immunity, if you're anywhere between 5 to 1,500, you're doing good, you're going to be symptom-free, even if the viral load is high. High viral load won't keep you in that range for too long, but you're going to have a few years where you're symptom-free. Once they go below 500, then you're at risk for an HIV minor thing. So seborrheic keratitis, I saw that a lot. They're going to get the little dry patches around their noses, their dry patches around their ears and their hairline. Again, you see that. And there's a couple other red flags, so you can get them tested. Then you get the generalized lymphadenopathy. Periodontal disease is huge. These folks, and there's hygiene, I'm sure, plays a part into it, but also the CD400, less than 500. In fact, there's a government program that if you're HIV positive and you're in poverty level, they will give the patient's medications for free, and a lot of dental care comes into that as well. There's a lot of dentists that kind of plug into that program and help out these folks. They get terrible dentition quickly. And then once you go below 300, then you've got the bacterial pneumonia, the TB, hence your TB testing. That can be just latent, and then it reactivates when their CD4 count drops, the cancers of all sorts. The oral candidiasis, I've seen that quite a bit. It's probably closer to 200 CD4 count, but I've seen that less than 300. And some can't get their CD4 count to more than that. They may have gone a few years with very low CD4 count, and with therapy, that's as good as we can get. So they're constantly coming down with thrush 2 to 3 times a year, which we can thrush. And once you're less than 200, these are your big major opportunistic infections. The esophageal candidiasis, incredibly painful, the cryptococcal, the PCP pneumonia, and your profound opportunistic infection, disseminated MAC or histoplasmosis. Disseminated histoplasmosis, you're not going to see that very often in immunocompetent cryptococcal meningitis. And then cryptococcal meningitis is what my patient with the multiple shingles outbreak, that's what he was hospitalized with, toxoplasmosis. So we will talk down the road. I'm going to go over this into more detail as far as starting Bactrim and azithromycin for as prophylaxis. So even if they're not infected, even if they're not sick, they present to your care, and they look healthy, they look fine. You get their CD4 count is less than 200. So you're going to start a Bactrim DS on some of these folks with low CD4 count because of how frequent the PCP pneumonia is in these folks. So when should we start antiretroviral therapy? Oh, yeah.
Is it considered AIDS when you get under 200?
Yes, yeah, that's the definition of AIDS.
If it goes above it, are they considered out of?
They're out, but they may still have a diagnosis listed as, that they've been there, but they're not officially AIDS status anymore. So when we start antiretroviral therapy on these patients, when I practiced, we pretty much followed a very strict number guideline. But towards the end there, already back in 2015, they started, well, not 2015, but 2010, they already started increasing CD4 count to when they would recommend starting therapy. And then within the year of me not practicing anymore, they finally changed the guideline, which said everyone with HIV positive status should start an antiretroviral therapy. And we didn't know this, and initially the medications were scarce, resistance, the medications were not as, they were effective, but there were a lot of adverse effects and side effects, and the lipodystrophy that we saw in some of the patients. So we kind of tried to weigh risk versus benefits. Once our therapy and our medications got so good, and we got so good at identifying figuring out what the mutation is, changing the medications, then we don't have to worry as much about medication side effects and toxicity. Now we're concentrating on preserving that immune system for as long as possible. You're still better off if your CD4 count remains above 700 the entire time versus you're one of those that dipped down, went into the status of AIDS below 200, then you started, your CD4 count came up. But that 700 that never dipped down versus 700 that came from the AIDS status, the immune system is still not as strong. So these folks are still at risk for some illnesses and cancers and heart disease and things like that. So the more of that immune system we can preserve, the less damage is done to the immune system, the better we are. Now, of course, with some of these patients, especially non-compliant patients, that's very difficult because you make your best call. Are you going to take it? Yeah, I will. You're going to take it. Okay, these are the side effects to expect. And if you get the side effect and freaks you, call me. We're going to talk about it. Don't just stop you. Yes, I will. Okay. So we don't have to, we'll start it when you see CD4 count is still 600. We're going to start. Okay, I'm ready. Okay, you're ready. So we'll start him, and a week later, a month later, he comes in, he freaked out, he got a little tingling or something, you stop taking it, and then you go, okay, I should not have started. I knew it. But it's a balancing thing. You want to preserve their immune system as long as possible, but once they start their medication, you beat it into them that you have to take it every single day. Don't miss a dose. Don't forget it. Take it with you. Carry it in your keychain. It's crucial. Think of it as cancer treatment. When you stop it, there's going to be problems. And so all that is out the window. We started all antiretroviral therapy in everyone if we can. Now, in some patients, we quite can't. Substance abuse, they come in at a clinic, you see them once a year, they check in, and somehow they're still keeping their CD4 count okay, their viral load is kind of low-ish, and as long as you can catch them once a year and check in on them, and when you have to, you have to. If they're starting to get some HIV-related symptoms, or even some of those minor, the seborrheic keratitis that come down with a little thrush here and there, even with CD4 count of 400 or so, that you would encourage even in some of these homeless, non-complying ones. And of course, if they go below 350, then you're just going to have to start. I mean, you need to. That's in the best, it's going to be malpractice in the patient's best interest for you to start, and keep your fingers crossed that he's going to stick with it and not, his virus doesn't become resistant to whatever you gave him. And there's a very, and I've already mentioned a little bit about that before, there's a very low, and I had one patient like that without antiretroviral therapy, his own immune system kept his viral load either incredibly low or borderline non-detectable. So the virus is sitting there in DNA, but it's not replicating. His own body is keeping it from replicating. But those folks, there's still some inflammatory process that's going on in these patients. We find that out because even though they've been on antiretroviral therapy, they still end up being at high risk for coronary artery disease, and that's an inflammatory process to the blood vessels and the plaque buildup. So there's still some type of inflammatory process that's going on, even without active replication. So, and eventually, their immune system may not do the trick anymore, and their viral load will come up, and you don't know when that day is. It may be 3 months before they saw you for your appointment. So that's a tricky one. We chose to follow those patients very frequently, and blood work every 3 months, and just monitor them. But you can argue that you can start antiretroviral therapy on them as well, because you don't know the day that their viral load may spike. So you want to improve the immune system, you want to preserve their immunologic function, you want to suppress the viral load, you want to prevent the transmission. The lower the viral load, the less infectious they are, reduce their mobility and mortality. This is a list of antiretroviral medications. Just in the past 10 years, they added 4 or 5 more to this list. So I'm going to talk about big ones and only using generic names. Your therapies, you have the you have NRTIs, you have NNRTIs, you have protease inhibitors, you have the fusion inhibitors, you have integrase inhibitors, and you have entry inhibitors. And if you were to take your best educated guess, you could see that these drugs work at a different cycle, different step of viral replication. The virus entering into the cell while it's replicating, or it's trying to exit out. These are all the NRTIs. From those, I think the combination, so this is a combination. So that's a lot of medications, a lot of drugs. So the pharmacists are coming out with, combine them into less pills, the better. And we eventually got our ATRIPLA, which is fantastic. And ATRIPLA is the umtricitabide, I'll show you which one it is on that list. Where is it? Okay, a blank. And you have your Truvada, which is tenofovir and tricidabine, which is the one up from the lowest one. That's the Truvada I talked about that is used for prophylaxis. And then you have the efavirenz and tricidabine tenofovir, which is the 4th one from the top. And that's your ATRIPLA. And if you're going to see a patient on HIV regimen, you may only see ATRIPLA on their medication list, and it is the most common prescribed a medication. Now, with the efavirenz, the only time I didn't use a triplet or chose not to in some of my pregnant patients who, or someone who's at high risk for pregnancy. If you have, in medicine, if you got uterus and ovaries, you can get pregnant, doesn't matter what they say. So if they've got functional uterus and ovaries, then you may want to use a protease inhibitor base. And there's a couple other reasons why you may choose protease inhibitor base. But for most patients, the NNRTI-based regimen, the top one right there, the triplet, was our choice. So we want to go back. So we want, when we choose a regimen, we want there to be either one protease inhibitor on base and 2 NRTIs, or 1 NNRTI and 2 NRTIs. Or you can do an integrase inhibitor where you have one integrase inhibitor like raltegravir, and then you add Truvada to it, which is the 2 NRTIs. So you always have 2 NRTIs in your regimen. And the third one, you can vary. You can have an NRTI, you have protease base, or you can have an inhibitor base. Now, the raltegravir, if I remember it correctly, was twice a day, I believe, at that time. So some of this also, the less pills they take, they just take it once a day, that's going to increase your compliance. In pregnant patients, again, we don't use the efavirenz. With the efavirenz, the risk of neural tube defects. I don't think I've mentioned why you don't give it to a pregnant woman, but there's a risk of neural tube defects. So if there's a risk that they're going to get pregnant or they are pregnant, you're going to stay away from that medication. So I think the most important thing out of all of this, as far as I'm concerned, for this part of the lecture, because you're going to get nauseating details on all of these medications, is to know that initial treatment is 3-drug regimen, 2 of which are in the same class, and the third varies. You're going to either have the integrase inhibitor, protease inhibitor, or an NRTI, but you're not going to do all 3 of them together, unlikely. Now, some of these advanced multi-resistant strain, working with the pharmacist, you may come up with something funky. But for most of them, this is what we're going to do. And then there's the regimen for the pregnant women. Again, twice a day regimen. It's a little bit harder to take for those folks, but we can't study pregnant women. So from these, the zidovudine, the lamivudine, the lecanemab, these were the meds that were one of the early part of early antiretroviral therapy, one of the oldest ones. And because most likely because we have most data on these medications as these women were becoming pregnant, and there is this large database that pregnant women, if they have no choice but to take their medications, there's this large database. You can go into the computer, find a website, and type in, what drug they were taking and what side effects or problem or adverse effects or what fetal issues that their baby had. And this is the best we've got because, again, we can't study pregnant women. But in pregnant women, I've had lots of pregnant women on this regimen. Sometimes if they're already on the efavirenz, I would change them. If they're wanting to get pregnant, I'll change them to this regimen. And then throughout their pregnancy, and I did not have a single HIV positive baby, but a big part of that is what was done in the hospital when they got tested, when they were pregnant, or right before their delivery, and they were quickly caught to start on the regimen. And so the risk of transmission from mother to baby is much, much lower. We just don't see that very much unless they give birth at home and completely ignore all prenatal care and haven't seen a doctor in years. And there are unfortunately still few babies out there that are like that. So the problem with them taking medications, of course, the more often they have to take it, the more pills they have to take. If they can tolerate them, dietary restrictions is not so much anymore, not with the newer regimen. And for like my patient that was dying in the hospital, denial. Substance abuse is in a lot of these patients, it wasn't a matter of whether they had any substance abuse, it's what was it? You know, you kind of already doc, what is it that they're using? Are they using heroin? Are they using cocaine? Are they, and you want to know this, because if there's an IV needle type of thing going on, then you need to try to educate them. You're probably not going to, just you in the clinic, get them off this stuff, but then you can keep offering them programs that are available, which, as you guys vote for the, I'll throw in some government in here, keep in mind how little mental health care we have in Oklahoma, and that is number one, and from what I've seen, was number one predictor of whether someone was going to be compliant or not. So it's a difference. It's not just, oh, they're depression meds, they're bipolar meds. It was a difference between, are they going to die of AIDS, or are they going to live? They're going to live and keep infecting others. You know, but a lot of these folks towards the end there, as a lot of the substance abuse places were closing, I had nowhere to send them. They needed help, they wanted to come clean, and I had nowhere to send them. You can't send them to ER, they're going to check them out, do blood work, and send them out. And they're not going to do much in ER. So mental health and inpatient facilities are definitely lacking in Oklahoma. The only thing I wanted to mention from this slide, and you're going to go into the side effects and major drug-to-drug interactions, is the protease inhibitors and many lipid-lowering agents. And she'll talk a little bit about as far as the drug-to-drug interaction. I just want to point out that you know, it can increase your cholesterol levels. So for some of your, especially older patients, you may want to get their cholesterol level checked. With the Reatas, a couple more big ones with the Reatas, which is Atazanavir and NRTI, we would watch for, they would get a little spike in their bilirubin levels, so sometimes I would even warn them, and they'd come back and their eyes are little yellow, and check their bilirubin, and if it's not too bad, they're tolerating it okay, I just kind of monitor and watch it, and it'll probably come down. No, they may have a little bit of slightly elevated bilirubin all along. Now, again, risk versus benefit, you yank that medicine out, starting on something new that they tolerate, you just kind of keep that bilirubin level kind of borderline and keep a close eye on it. The zidovudine can cause macrocytosis, just a blood work thing that's not going to really make them anemic or do anything else besides that. For most patients, and the tenofovir, we watch their creatinine level closely, and of course probably try to avoid it if they had some major renal impairment. So we talked about getting them vaccinated. They're going to need the vaccines. You know, there's a question over the attenuated vaccine versus, you know, you want to do the killed, the non-attenuated vaccine. But some of my patients, if their immune system, if their CD4 count is very high, they probably could do an attenuated vaccine too. I mean, we're talking about like inhaled, flu vaccine where they do it in the nose rather than the shot. But generally, I recommend it to avoid any. You want the killed virus particle. You don't want a half-alive virus introduced into their body as a part of vaccine, which there's not that many out there. I'm going to do pap smear. Cervical cancer is much more rampant in these women, and I did it every 6 months for the first 2 pap smears initially as they presented to care, and then you do yearly, but not less than once a year. They've changed the guidelines where if you had a normal pap, they used to demand yearly, doesn't matter why, but now they've changed the guidelines for just healthy woman, if she's had normal pap, she can, I don't know, 3 or 4 years or something like that, correct me if I'm wrong, but not with your HIV positive patients. Even with a fully good immune status, you want to do them once a year, even if they're on antiretroviral therapy, non-detectable and viral load grade. And of course, if you're got the your pap come back as ascus cells, then they're gonna need to do colposcopy. You know, with some of these, you kind of triage based on what kind of HPV strain they have. If it's more virulent, you do colposcopy. For some, you may not. But for these women, again, you just have a much higher suspicion for cancer, and you are a bit more aggressive with these women. As far as all the other screening, like breast cancer and colorectal cancer and prostate cancer, that is just the regular guidelines. That was no change, and I've already mentioned that. So if they do have a positive PPD test, for the HIV positive patients, especially if they're very immunocompromised, they may actually not even have the immune system to cause the induration on the PPD. So, but we keep the guidelines. It's usually, I believe, 10 millimeters. For these patients, it's 5 millimeters. So if they have a little induration, we were walking around with the rulers, and we have a lab called, come here, get the ruler out, and you're measuring it out. And this is something that's health department is going to do. Unless you work at health department, you're not going to be treating latent TB or. But if they haven't, if you tested positive and you have a very low suspicion for positive, maybe 4 millimeters, and you go, I'm going to call it, then they're going to get, most likely get the treatment for about 9 months, and it's just one antifungal. They're not going to get your typical 3-4 drug regimen like you would treat TB, unless you're actually diagnosing with an active infection, and that's another story. I think I've already mentioned all of that. So the Ryan White Care Act is the government program that I've mentioned. So back in 2009, when I gave this lecture at the PA conference, you had to make less than about 200 a year. So that may change. I can't imagine it changing a whole lot. So if they make very little, the government will supply their medications, their health screenings, all their vaccines, some even dental care, and some even go as far as certain surgeries and things like that, as doctors kind of participate and plug into that program. So we want these patients living healthy and compliant.